speaker. Okay, Dr. Lin will in charge of the section. Dr. Lin.
Good morning, everyone. Let's move to the next session. We'll talk about what you should know when we come up to hilar stenting. And here I will introduce the speaker, Dr. Guo Yu-Ting, and he is an expert in therapeutic endoscopy, and he is now an attending physician in the Division of Endoscopy, Department of Integrated Diagnostics and Therapeutics, National Taiwan University Hospital. He is also very experienced in therapeutic hepatobiliary procedures. So let's welcome Dr. Guo, please.
Thank you, Chairman. Your kindly introduction. And today is my great honor to have this opportunity to share today's my talk. My talk is what to know for hilar stentings in malignant hilar obstructions. Because today's my talk will just focus on hilar obstruction. So malignant hilar obstruction mostly will occurs caused by primary biliary tract tumor in the hilar. We call that the cholangiocarcinoma tumor, and some caused by adjacent cancer, just like gallbladder cancer or surrounding lymph node to cause extrinsic hilar compression. In this kind of malignant hilar obstruction, the prognosis is not so good. It's very poor. 5-year survival rate almost less than 10%. And another hand, at the initial diagnosis of malignant hilar obstruction, around 70% of this kind of patient cannot receive operation. We call it unresectable. So how about the indications for biliary drainage in malignant hilar obstruction? Mostly we will arrange this kind of procedures if the patient have the symptoms just like the pain or jaundice, and some very afraid of the adverse event occurs in the future, just like the pruritus or cholangitis. And some patient, because the patient maybe can receive operation, and some surgeon we need to relieve the biliary obstruction, and some because chemotherapies. So when we meet the patients have a biliary obstruction, we have some step to evaluation. I will summarize this in this slide. The first step, we need to make sure the stenosis location is a distant part or hilar obstruction. And then you need to evaluate these patients, the current disease status can receive operation or just for palliative drainage. And the third step, which kinds of drainage route is the better for this patient? Is the percutaneous or ERCP with internal drainage? And another choice is the most also very popular method, US guide biliary drainage. And the lesser part, if you want to perform the endoscopic drainage, which kinds of stent you will prefer, plastic stent or metal stent? And which kind of metal stent, non-cover, partially cover, fully cover? And in hilar, you need to consider the stent methods or stent by stent method. And in the following slide, I will share in some current evidence and our experience. The first, I will talk about pre-operative drainage in this kind of malignant hilar obstruction. The first, you need to discuss with your surgeon how about the value of a pre-operative biliary drainage, because in 2018 ESG guideline they against the routine pre-operative biliary drainage. Just you need depends on the patient, because in this kinds of patient, if you perform a pre-operative drainage, no matter percutaneous or internal drainage like ERCP, have some morbidity rate report in some meta-analysis. So in ESG guideline, they will not suggest routinely to perform preoperative drainage. How about in this month, the recently published in SG, the guideline is the most recently guideline in preoperative drainage. If the patient need to receive in a multidisciplinary team, according to their suggestion, they were against use the percutaneous drainage compared to endoscopic drainage. And the reason, I think they have two major concerns. The first is in this recently randomized control trial, they find that the percutaneous drainage group have a higher mortality rate compared to endoscopic drainage. And this study very early to terminate because they find that early mortality rate in percutaneous drainage group. And another issue, they find that the PDCD group have more risk for tumor CD metastasis. Even in this meta-analysis, they find that the internal drainage can decrease around 70% risk to decrease the CD metastasis. And in this Japanese group, they find that the preoperative drainage under endoscopic drainage have longer survival. And in the other hand, the percutaneous drainage have the six times the peritoneal seeding rate compared to endoscope the internal drainage. So this is a reason why this year's SG guideline, if they will prefer endoscopic drainage compared to percutaneous drainage in preoperative the drainage in malignant hilar obstructions. How about the palliative? I think that is a very important. The consensus is organized by Professor Ransons in 2013 in Thailand, and at that time it's around 10 years ago. In the palliation for the Bismuth 3 and the Bismuth 4, at that time the percutaneous stenting is superior to endoscopic stenting. However, recently, our endoscopic technique and the device is gradually improved. And in 2018, the ESG guideline, if the patient is below to the Bismuth type 1 and 2, ERCP for biliary drainage, internal drainage is the preferred. How about is the type 3 and the type 4? Maybe you can consider percutaneous drainage or combine percutaneous drainage or ERCP to achieve the palliative drainage. And the paralysis, I think that this study, most of you also know it. If you want to perform palliative drainage in high-grade malignant hilar obstruction, just like Bismuth type 2, 3, and 4, you need to drainage at least 50%. They can decrease the mortality and the mortality. I think in hilar obstruction, the anatomy is very important because you can see that the first branch of the left side HD is around 3 centimeters. It's longer than right HD to separate. So this is why the right branch in a hilar in a clustering tumor, the right branch is more easier compared to left side. So the preoperative procedures, the image is very important, just like the no matter ERCP or CT scan. Before you perform the biliary drainage, I think you need to make sure the relationship between obstruction, just like this one is a type 3A. The right anterior and the right posterior already separate. So this is type 3A, and left branch is not involved at all. So in this very huge retrospective studies in China, they enroll mostly is high-grade cholangiocarcinoma, and the most and the one of four only 25% have received the chemotherapy. In other hand, they also palliative, not receive any chemotherapy, and they find that bilateral stent deployment have the better outcome compared to unilateral stent, no matter plastic or metal stent. And in the other hand, if you place the metal stent, that bilateral metal stent have the best outcomes compared to bilateral plastic stent. So in this randomized control trial organized by the Korean, they also find that the stent, bilateral stent, they use the stent-in-stent method compared to unilateral stent. They also find that the stent patency rate is longer and have a fewer reintervention rate. Also, the overall survival rate have no significant difference, but the things is higher compared to unilateral drainage. So in this year, SGA guideline also suggests for unresectable malignant hilar obstruction, they will suggest a bilateral stent compared to unilateral stent. And if the patients have very short life expectancy and prefer not to receive the ERCP very frequency, the bilateral metal stent is the first choice. In the other hand, if no very clarifies optimal drainage strategy, after discussion to other oncologist or surgeon or patient, maybe bilateral plastic stent will be the better choice. So how about a bilateral stent? We have two methods. The one is the stent by stent method. You can simultaneously to place the stent and side by side. This is a stent by stent method. And another is the stent in stent method. Is a more complex and sometimes it's not so easy. Just like in this case, we place the two guide wires into we wish place the HD stent, and usually we will choose the more angulated the target more angulated biliary duct. So we will place the first uncover stent. This is a bona and hilar stent. You can see this is a cross area, and then slightly withdraw this guide wire and select to a right branch. Sometimes it's the most difficult part, and then if you successful to find the way to the right branch, and then you can press another stent in the previous metal stent. This is called a stent-in-stent method. So how about these two methods have any different kinds of outcomes? In this also is a Korean group. They compare stent-in-stent and stent by stent, use the same stent in high grade malignant hilar obstruction. They find that the very similar no matter technique, clinical success or long-term outcome, including adverse event and survival. They don't find any difference between the two groups. So if you want to place the endoscopic drainage in the hilar malignant biliary obstruction, I think it's a very challenge because the anatomy there is very complicated, and sometimes and many interrupted branch you will see while you inject the contrast, and sometimes you will encounter some very tight stricture, and sometimes after surgery the anatomy will change. So I think that compared to distal biliary obstruction, the hilar obstruction is more complicated, and sometimes the technique and is lower than distal biliary obstruction, and sometimes it's more easy to occur post-ERCP cholangitis. So how to successful to place the endoscopic stenting in malignant hilar obstruction? I think you need very experienced in this kind of procedure, and you need have a very skillful assistance. And I think the most important is that before procedure, you need to check the MRCP or CT to make sure which duct you want to place the stent to achieve at least 15% drainage. And you need to prepare some proper accessory, just like a guide wire, dilator, and a specialty stent. And sometimes you need your colleague, especially interventional radiologist, to back up, because sometimes you will not always success. And the last one is that before procedure, you need to give the prophylactic antibiotics. How about a tip? I think I want to share some tips during this kind of procedure. You should limit the injecting to contrast. And if you inject the contrast in the biliary segment, you need to attempt to drainage your inject part. And another important part is avoid injecting to the atrophy ligament segment, because this kind of segment is no need to drainage, because they were not effective in a clinical. And the last part, try your best to drainage at least 50% of the liver volume. So while you prepare the procedures, you check you want to place the stent the target biliary segment, and then you need to place the guide wire. I think this step, the most challenge is the selective cannulation. And the third part, before the prosthetic stent, you need to dilate to overcome the test stricture. And finally, you can place the stent and finish the procedures. How about the accessory is very important. I will separate two parts. The first part is selective cannulation. You need to proper guide wire. Sometimes, usually, we will use angle tip, the guide wire, and sometimes you can change the tip, just like a sphenotome, like the rotatable sphenotome or swing tip catheter. Sometimes you can use a balloon to inflate balloon to change the duration, and also sometimes if you patient use a brushing, and you can use brushing catheter to select cannulation. And a dilator, and you can separate, you can use a dilation balloon or catheter dilator or Soehendra stent retrievers. I will show some videos. Guide wire have several different kinds of characteristics. Usually, just like a talkability and the pushability, and the angle tip, the hydrophilic part is very important, and especially the bunking. The buckling and the bending, the character also very important for your selective cannulation. Just like usually we will mostly use these kinds in a very difficult case, we will choose the Nitinol wire because this is very totally hydrophilic, and another is the Navipro, the Boston Scientific, also totally hydrophilic, and usually another company, many companies can offer angle tip the guide wire. I will show this kind of very difficult selective cannulation case. We want to selective cannulation to right branch, and initially we use a regular angle tip the guide wire. This is a VC guide, and however, it's not successfully to right branch. So we try very several times. Then we change to the Nitinol wire. So okay, this is Nitinol wire. It's a very how to say that, is because it's hydrophilic. So sometimes it's very easy to control the direction of the guide wire, and it can very easier to reach your desired the biliary segment. And the shape of a different kind of angle tip guide wire is different, and mostly and the length and the angle, the shape is different. So according to your preference, you can try to choose which ones you like it. And another is very important is assistant wire is very important because you can use two kinds talkability. You can use your hand or use your another device. But this I think is sometimes very inconvenient because sometimes it's very hard to push or out. So sometimes we will take off the glove and use the hand to rotate it. I think it's quite useful. And another part is the looping measure, because just like the hydrophilic the length of this hydrophilic part, I think the longer is more easier to achieve the looping measure. So just like this case, difficult case, sometimes you can use looping measure and using the probability, and they can very easier to find your disturbed weight. So I will show this case. This case we use the guide wire, and we will try to make the looping and use the property of anti-buckling and bending, then select the probable way, and they can use their property to become the looping to your like the biliary segment. And then sometimes straight type the guide wire also can use, just like this case. I will use a straight type angle, a straight type the VC guide, and you change the catheter's the direction. Sometimes you use the straight type the guide wire also can achieve. So I think this selective cannulation will case by case. And I will show this another one case. We use the brushing catheters, because sometimes indeterminate biliary stricture we will using this kinds of brushing catheter to brushing, and you can see the brushing catheter always sometimes will go another way. And after you brushing the biliary stricture, you can withdraw and push the guide wire into the brushing side, and use this two guide wire method. And sometimes it's very easier to let you find another weight in this kind of case. Okay. How about dilatation? Dilatation is sometimes very important. We can use dilatation balloon or mechanical dilators, and sometimes very difficult case you need to use Soehendra stent retrievers. Or just like this very tight stricture, even a catheter 5 French catheter cannot go through. So we can this kind of very tight stricture, very thin catheter cannot put. So we can use this kind of Soehendra stent retriever to screw in and with your assistance, and slightly withdraw your guide wire, and you can slightly push the Soehendra stent inside, and then catheter can go into, and you can do following procedures. And this is another kind is Soehendra dilator, is bougie dilators. It's just very like the press the ERBD. So it's a very easy use different kinds of size to dilate the biliary strictures. And another kind is a proper balloon dilatation. I think is very useful, and sometimes it's very effective to dilate in very tight strictures. And the choice finally is choice of a stent placement. The placement the stent is depends on a plastic stent is another issue, but now we will prefer the metal stent in most cases. And because different kinds of methods, you need to choose different kinds of another issue is the delivery of stent. Some stent is mostly a non-cover stent is the same French, and some specially designed is the C French. Just like the M.I.Technology is the HANAROSTENT. It's very like the Cook zebra stent is only 6 French, and but it's different. It's a cross cell type, so they can if you withdraw deploy the stent, you can also capture the stent back. But in a Cook zebra stent cannot, and it's very thin. So I think it's like advantage. And this I want to show this gallbladder cancer caused hilar obstructions, and we after press the guide white in to separate biliary left and right biliary HD, and then we will place the one in the right HD. And you can see it's different from Cook zebra stent. They have another marker in the center part. And usually we will place the 2 stent in the distal part at the same level. And we prefer simultaneous deployment. And the correct advantage of this kind of stent, if you think it's not proper positions, you can recapture, and then you can deploy very smoothly in this case. Okay. So another now have some paper have another idea is multisectoral stent placement. They want to achieve almost completed drainage, not only above 15%. So in these papers, they place the multiple stent to drainage the stent to drainage obstructive the biliary system, and in their limited case, they find the outcome is pretty good. Early adverse events with 0, and only 30% have the late complication. Okay. Because of time's limit, so I skip this video, this 3 stents by stents in our one case, and another case is stent by stent, also press the 3 stent because time's limit. So I will not show this video. I'm very sorry, and I think this also okay. So I want to summary today's my talk, because the malignant hilar obstruction is sometimes very difficult because you will encounter very difficult part. But recently in the HG guideline, they find that if you want to perform the preoperative drainage, ERCP guided biliary drainage will preferred. If the patient is below 2 unresectable malignant biliary obstruction, I think the bilateral stent is preferred. And in very short time, short life expectancy, I think the bilateral metal stent is better. And in other hand, bilateral plastic stent will be another choice. At the last, I want to share this paper. I think it's a very interesting, and I very like this paper because they find that because we sometimes perform stent or stent by stent stenting. Sometimes the most challenge is the restenosis. Sometimes in this kind of restenosis, we will difficult to intervention. So in this paper, they find that the stent, you press the metal stent first. If the restenosis, they have 15% the case cannot success to reintervention, and the most part is endoscopic revision failures. So they find that this case have 2 times the risk to for the patient to need to receive the percutaneous biliary drainage in the following date. So I want to show this paper because I very agree with this author. They use the state up the step-up drainage strategy, because if the patient cannot receive anti-cancer therapy, if have a longer survival, and maybe you can use metal stent. However, if they can receive the chemotherapy, you can try use a bilateral plastic stent the first. I think because it's more easier to do a reintervention. But if the patient's disease become the progression with poor response to anti-chemotherapy, and or patient no want to exchange very frequency, I think you can consider to conversion to metal stent. Okay, thank you. This is my today's talk. Thank you very much.
Thanks, Dr. Kuo, for excellent talk. And now we have some questions from the audience. Okay, Dr. Chen Jiachang would like to ask, for high-grade malignant biliary obstruction post-endoscopic biliary drainage, re-intervention is frequently needed. If metallic stent was occluded, which procedure, PTCD or ERCP, do you prefer for re-intervention? And what is the successful rate of PTCD or ERCP in this situation? Do you have any comments, Dr. Kuo?
Thank you, Dr. Chen's your question. I think it's very important because re-intervention rate is always very is important issues. If we place a metal stent, and usually we will try our best to do a ERCP first. And just like the last paper I showed with you, we also encounter some failed case. So sometimes the failed case, we will let patient to receive percutaneous. So currently, we don't have a very definite treatment strategy. We will place the prostate stent first to avoid this kind of reintervention difficult in metal stent.
Okay. And another question from Chen Jianhua. And generally, the development and the deployment of stenting stent is in the bile duct. And if there is any circumstances to place the stent across the papilla.
Thank you, Jianhua Laoshi. You're very good questions, because I think it's a very good issue. Sometimes some papers show that the transpapillary placement will have a higher duodenal reflux and recurrent cholangitis compared to suprapapillary method. However, in suprapapillary method, we will encounter some difficulties reintervention. So I think all of them have some trouble, but up to now, according to my experience, I think there are no definite issues. So mostly, if we can, usually we will place the suprapapillary method, because in stent sometimes we think the place the guide wire is more easier than stent by stent in suprapapillary method. Thank you.
Okay, we have so many questions here, but the time is limited. So I suggest that Dr. Kuo answer these questions in the chat room, and we move the session. We'll move to the next session.
Okay. Okay. Thank you. The next session